Type 1 interferons have a large and circumstantial database supporting their involvement in the pathogenesis of lupus. I'm not going to go through that in detail. They are also, as everyone knows, part of the innate immune system's response pathways. The type 1 interferons work by a common receptor and a common mechanism of signaling, and then activate gene expression through interferon signaling elements. This will become important because we're not only looking at Rontalizumab, which is an anti-interferon antibody, but we're also looking at the gene expression profile of our patients in this study. Rontalizumab only blocks type 1 alpha interferons. There are 12 of them in humans that are unique. We have no activity against interferon beta and kappa, for example. It is an IgG antibody. We evaluated sub-Q and IV regimens in this study, and some preliminary information about the phase 1 study results have previously been published. As those of you know, there is an interferon signature in lupus patients. There are over 100 genes, and as part of a perspective of looking at a potential diagnostic or efficacy biomarker for Rontalizumab, we tried to simplify the interferon signature. We were able to do that to the level of using 3 genes that in high correlation with the overall signature were basically a surrogate for the interferon signature in patients. Interferon signature in patients actually is not distributed what we thought at first in a complex way. It's possibly oversimplified. Healthy patients, or not patients, really healthy volunteers, they have a unimodal distribution. In fact, it got a little shoulder there. That shoulder is actually women who have a slightly higher expression compared to matched male healthy subjects. In the phase 1 study, we saw a bimodal distribution, about 50-50 between what we call ISM low and ISM high. In the phase 2 study, which enrolled moderate to severe SLE patients, there is again a bimodal distribution, but now it is skewed slightly. It is about 3-to-1 ratio of ISM high to low. Importantly, there is, as far as we can tell at this point, no differentiation in disease activity, or as some people sometimes call subphenotypes of lupus, based on the ISM low and ISM high characterization. And I'll show some of that data. The ROSE trial, a phase 2 study, was actually designed with lessons learned from previous experience based on Explorer, particularly in extrarenal lupus. And some key elements of it are that the patients who were enrolled in this study were allowed background medications. They were allowed also steroid as part of a screen and taper in the course of the study. But immunosuppressants, azathioprine, methotrexate, etc., were at the point of initiation of randomization or during the screening period discontinued. So the results of this study are actually only on background medications of steroids, hydroxychloroquines, and NSAIDs. Enrollment is shown there at about a 2-to-1 ratio, and the ACR classification criteria were used to enroll the subjects, including ANA positivity. We did not enroll patients with unstable neuropsychiatric lupus or with frank lupus nephritis or APS syndrome, unstable. The primary endpoint was a BILAG responder index at 24 weeks. The secondary endpoint in this study was the SRI, as people are now familiar with, and there were multiple exploratory measures. There's actually 2 studies. We did not feel it was prudent or wise or ethical even to do both sub-Q and IV infusions to maintain a blind. So they were actually separated regimens, and so they're separate studies. And I think in the end that was actually very helpful for us, although that was not the intent. The first part of the study started with IV administration once a month, and the second study or sub-study was a sub-Q regimen, 300 milligrams every 2 weeks. The number of subjects are shown there. The steroid taper that I described began for those who needed steroids in the screening period, and then were tapered down by 6 weeks, and then physicians and their patients were encouraged to decrease the steroids as tolerated. And the primary endpoint for the first part of the study, or an interim analysis, occurred in November of 2010. The study actually continued separately for the sub-Q, so it's really a separate cohort. There's an ongoing part 3 to the study, which is an open label extension. I will not be talking about that for this particular discussion. Very briefly, the patient demographics are very reflective of the regions and the number of sites in the countries, including Russia, Argentina, Mexico, Poland, Colombia, and the US. We had a very high completion rate through the treatment endpoint period and also through the entire treatment period. And we also, and that's not shown here, have a very high overall rate into the open label extension. Racial distribution is as shown, and ethnicity. The gender is not surprising given lupus studies. What is shown here is the ISM status at baseline based on those 3 genes as a surrogate for the interferon signature, showing that 3-to-1 ratio of ISM high to low. The baseline characteristics are very easy to see in the circumstance of the pooled data where you have placebo versus Rontalizumab are fairly well matched in terms of age, lupus duration, the BILAG index. In terms of this being an entry criteria, almost all patients will have at the end either 1A or 2Bs, but the level of distribution of severity by 1A or 2As is fairly balanced. The BILAG index score is roughly 11, Salinas-Ledi score mean is roughly about 10, and the PGA score is shown. There were about 1/4 to 1/3 of patients on immunosuppressants, but those were patients who would have discontinued them in order to be randomized. And the number of patients who are on steroids is roughly about 80, almost 90%. Fairly well balanced, mean doses around 9 to 12 milligrams. Other important points in terms of the serological characteristics, most patients were ANA positive, anti-double-stranded DNA. There is some variation between here. It is not particularly well matched in this spectrum of 40 to 66%. Anti-ENA extractable nuclear antigens are fairly balanced. There was some level of hypocomplementemia, C3, C4. It seems to be pretty well balanced. And what distinguishes is the ISM status. To the point that the disease manifestations that we can capture by BILAG, Salinas-Ledi, PGA, or even some more objective findings in micro detail in terms of swollen joint count are fairly well balanced between ISM high and ISM low. On the other hand, there is a serological difference. The ISM low patients do not have the same degree or level of, say, serological abnormalities by double-strand DNA level, by extractable nuclear antigens, and also by hypocomplementemia. They seem to have overall in the ISM low less serological abnormality. But it is a spectrum between here. It's not very black and white. The results overall is shown on the left with the primary endpoint, the BILAG. For all comers, and this I will, for the purposes of time, use the pooled data, we did not meet the primary endpoint by BILAG. This is, again, frustrating for us who have been through that experience with Explorer and the difficulty of working with BILAG. Even if we look at the ISM or ISM low, we cannot distinguish the treatment effect. On the other hand, with the secondary endpoint, the Salinas-Ledi Responder Index, or SRI, there is a difference, not in the all-comers and not in ISM high, but in ISM low. This is one of the surprises from this study. We went in with the hypothesis that it would be the ISM high that would be most likely to respond or more robustly respond. This is not the case, in fact. But there is a pretty good magnitude of response, 31% compared to the placebo. If we look at the higher threshold clinical activity by SRI 5, 6, and 7, the most important aspect of this is it really does blunt the aspect of any placebo response, but there is still a significant treatment difference by SRI 5 and SRI 6, although there is a delta here that's not statistically significant for the SRI 7. There is another point. Unfortunately, because it is the ISM low, which represents about 1/4 of the patients, we are talking about small numbers here. And just to illustrate for SRI 4, we have in the placebo group 2 out of 11 responding versus 12 out of 17. It's only when you get up to the pooled numbers that you could start to say you've got a certain number of patients. But this actually is one of the confounding features of trying to interpret the data, that in the response group we have a very low number. Fortunately, the IV group has efficacy, was looked at first with the expectation it was ISM high. We looked at this now prospectively in the second study to say, well, maybe it is ISM low that's responding, and it seems to be confirmed now in a separate cohort that the ISM low is the responding group by blocking alpha interferons. But other activities seem to show some treatment benefit. For example, there's a reduction in flares, and this shows a Kaplan-Meier plot from the 0 time point out to 24 weeks, and showing differentiation really after week 12, which is the time of the steady state for this monoclonal antibody. And the hazard ratios are for the IV and sub-Q and pooled data showing benefit in terms of reduction of that flare frequency. We were also able to show by decrease in prednisone use, in this case it's less than or equal to 10 milligrams per day, a reduction of steroids in the ISM low group, 24% compared to the placebo group, not so apparent in all comers or ISM high.
You are over the time.
Safety, very good overall. We do not see any safety signals, except there was an increase in SLE flares. These 6% versus 1, they were all in the ISM high patients. There were no SAE flares in ISM low patients. So why is the ISM high the responding group? There's a lot of ideas we can go through in question. We do think we hit the target. We can demonstrate that by PD effects on other interferon-regulated genes. We decreased it by 40 to 60%. We do not, by this treatment, make ISM high patients into an ISM low category. There's not that sort of effect. But the ISM low patients certainly go into the more normal range of, say, basal interferon expression. We feel we've dosed high enough. We are molar excess above almost all of these interferon isoforms. And the ISM seems to be telling us that there are some things driving that are not totally blocked by type 1 alpha interferon. It's possible that the type 1 beta or other forms may be contributing to that signature. There may be immune complex formation. There's some data external and internal that suggests that immune complexes can also drive this immune interferon signature. But at least for the ISM low patients, we are seeing what we think is blockade activity that may be driven partly or exclusively by interferon, or at least low levels of interferon that are abnormally signaling in the pathogenesis. So I would like to thank people in the study, our patients and the sites and our investigators who entrusted this, and the hosts for inviting us. Thank you very much.